Okay, so I made a little video as an overview of pancreatitis. I decided to do this to help myself study for my exam, but also if it can help somebody else, why not? So I figured I would go ahead and post it, and just learning it well enough for me to teach it really helps me process the information. So thank you for watching this. And again, I hope it helps. Keep in mind, I'm not perfect. I make mistakes. I did get all of this information either from the textbook, the professor, or pals, and I just kind of put it all into my own notes, which I'm going to be sharing with you guys. And yes, there will probably be spelling errors and some other things you could probably point out to me, but just take it for what it is, and I hope that you get something out of it that helps you on your exam.
Pancreatitis is an acute inflammation process of the pancreas. Spillage of pancreatic enzymes spill into surrounding tissues, causing autodigestion and severe pain. This can vary from mild edema to severe necrosis. In order to understand the full effects of pancreatitis, we need to understand the typical functions of the pancreas. Typically, the pancreas has two functions, exocrine and endocrine functions. As in our cells secrete inactive digestive enzymes into the pancreatic duct, and they do not typically activate until they reach the duodenum when mixed with stomach acid. These enzymes include amylase, lipase, and protease, which are responsible for breaking down carbs, proteins, and fats. Epithelial cells, which secrete bicarbonate, as well as endocrine cells, which are responsible for insulin and glycogen production. In a typical healthy person, these digestive enzymes would leave the pancreas. However, with inflammation, these pancreatic enzymes are released inside of the pancreas and autodigestion begins to occur. There are several causes for this inflammation process. The main reason is typically gallbladder disease or gallstones, which will cause a block in that duct, the pancreatic duct, and the enzymes we just spoke about will begin to back up. And once they back up, the activation process and or autodigestion begins to take place, which causes the irritation and the inflammation. Another main reason for this would be chronic alcohol intake. Alcohol also causes damage to those same pancreatic cells, and this decreases the production of bicarb as well as the fluids that are typically secreted by the pancreas, and it causes a viscosity within that pancreatic duct and causes an occlusion and activation of those same enzymes inside of the pancreas. There's some more or less common reasons, such as smoking, hypertriglyceridemia, trauma, viral infection, and certain drugs or metabolic disorders. So to summarize, alcohol or biliary tract disease can cause activation of pancreatic enzymes and injury to pancreatic cells, which can cause the following effects: edema, necrosis, hemorrhage, vascular permeability, smooth muscle contraction, and or shock. And lipase specifically causes fat necrosis. Now that we have a better idea of exactly what is going on when we talk about pancreatitis, we can discuss some of the clinical manifestations. Since the pancreas is located in the left upper quadrant, the patient will feel severe pain in the left upper quadrant. It sometimes will radiate to the back. This pain is always aggravated by eating as well as lying down. You might see flushing, cyanosis, dyspnea, nausea, vomiting, low-grade fever, leukocytosis, which is a low white blood cell count, hypotension, tachycardia, jaundice, often with worsening cases, elevated glucose due to those isolate Langerhans cells dysfunction, abdominal tenderness with guarding, crackles in the lungs, abdominal skin discoloration, and this is due to the digestive enzymes in the surrounding tissue that we talked about with the pathophysiology. This can cause bleeding into the area as well as irritation. This can present physically as two different skin lesions. One is called a gray Turner's spot, which is a bluish coloration in the flanks. And there's also the Cullen sign, which is a bruising around the umbilicus. Both of those are late signs. Shock is also a manifestation, as well as elevated amylase enzymes for the first 24 hours. A normal amylase will fall between 56 and 90, and a normal lipase is from 0 to 110. So those will both be elevated typically with pancreatitis. When you think pancreatitis, I want you to think of the complication paralytic ileus. And with that complication, bowel sounds may be decreased and or absent. Some other systemic complications include pleural effusion, pneumonia, ARDS, hypotension, and hypocalcemia, which is a huge one. You want to monitor the patient for tetany, as well as a positive Trousers sign or Chovstek sign. Sorry, I cannot pronounce those. However, one is where you stroke the cheek, and the other you use the blood pressure cuff on the forearm, and that is to check for hypocalcemia, and either of those signs being positive would indicate hypocalcemia, and you want to treat that with calcium gluconate. The care for pancreatitis is mostly what we call supportive care or comfort care. We are going to just treat the symptoms and or the cause if we can, but mainly we're treating the symptoms and trying to prevent the patient from getting worse. So like I mentioned, these patients are in severe pain. Our number one goal is going to be to relieve their pain, give them morphine, an antispasmodic. We also want to prevent and or alleviate shock. And we can do this with plasma or plasma volume expanders, which is dextran or albumin. We also want to decrease the pancreatic stimulation and or secretions. And this is because, like mentioned earlier, the pain is aggravated by eating, and that is due to the release of the enzymes that happens when we eat. So these patients are going to remain NPO, no food, and to give the pancreas a rest. We're also going to keep these patients on NG suction to decrease the acid secretions and slowly provide fluids and enteral nutrition as tolerated. But we really want to let that pancreas rest, which is going to be the number one way for it to recover. Pancreatitis is an acute response. It is reversible. Rest is going to be the best way to achieve that. We also want to correct and monitor any fluid and electrolyte balances. Aggressive hydration is going to take place. We are also going to manage any metabolic complications, such as providing oxygen and monitoring glucose levels, prevent and treat any infections, remove any precipitating causes, such as those stones that we mentioned earlier. And like I said, supportive care. We need to keep an eye on the hypotension by providing vasoactive drugs such as dopamine and prevent infection. So nutrition is going to include low fat, high carb, and we will provide antibiotics if necessary. And the pain medications, antispasmodics, carbon anhydrase inhibitors, antacids, and or proton pump inhibitors. The reason for the proton pump inhibitor and the antacids is due to the fact that those acidic secretions will be high. Since we mentioned earlier that the bicarbonate is secreted by those cells that are now having dysfunction, we are going to have a more acidic environment. So it is very important to provide those antacids and the proton pump inhibitor. Chronic pancreatitis is a chronic inflammation of the pancreas, which is typically caused by long-term alcohol abuse. Long-term alcohol use causes recurring inflammation and damage to the structure of the pancreas, where in acute pancreatitis, there's actually not a change in the structure, just a temporary change in function. With chronic pancreatitis, we will have a permanent damage to the structure and function of the pancreas. The clinical manifestations will look similar. The patient will also have pain in the left upper quadrant. It may not be as severe. However, it will feel more like a heavy gnawing feeling or a burning, cramping feeling, typically after alcohol intake and or eating. Malabsorption and weight loss is also very common due to the fact that those pancreatic enzymes that break down and help us absorb nutrients are no longer being secreted and or used properly. This can cause also constipation and jaundice. You will often see dark urine with chronic pancreatitis due to the bile buildup that ends up being excreted through urine. Streatorrhea will be seen with these patients, which is fatty bowel movements. You will see typically fatty diarrhea. And diabetes mellitus is also common with these patients due to the damage of those pancreatic cells that control blood glucose. Basically, the manifestations are similar but more severe, and due to the fact that the structure has completely changed, there may also be pseudocysts visible within the pancreas. There could also be a physical bile duct or duodenal obstruction. Pancreatic ascites and or pancreatic cancer is sometimes a complication. Diagnostic studies include increased serum bilirubin, increased alkaline phosphate, mild leukocytosis, increased sedimentation rate, and surprisingly, serum amylase and lipase will be normal or slightly elevated. And this is due to the fact that the pancreas is just not working properly. With acute pancreatitis, we're going to end up with an oversecretion of those, and some might still pass by and make it into the bloodstream, where here with the chronic pancreatitis, that is not the case. Glucose intolerance and or diabetes may be common as well. And the most common diagnostic will be that streeturia we talked about. So a stool sample will be taken, and a decrease in fat-soluble vitamins is typical. So the care for these patients is still going to be supportive care. We will still provide those analgesics for pain, and morphine and or a fentanyl patch could be given. This patient is going to be on a specific diet. It is going to be a bland and low-fat diet with small, frequent meals. This patient should stop smoking. No alcohol or caffeine intake. No alcohol because we said it is the most common reason for pancreatitis. Alcohol needs to be eliminated. Pancreatic enzyme replacement is now officially needed now that we have gotten into chronic pancreatitis. And that means they will typically sprinkle that enzyme on their food when they eat, as well as replacement of bile salts. Insulin and or oral hypoglycemic agents to help with that blood sugar stabilization. And we still need to neutralize that acid, same as acute pancreatitis, by providing antacids and or proton pump inhibitors. Psychosocial is also important to consider with these patients since it is a chronic process. Antidepressants should also be considered if the patient is feeling depressed. Surgery is indicated when biliary disease is present and the obstruction of a pseudocyst, which diverts the bile flow or relieves the ductal obstruction. They can also have endoscopic procedures such as pancreatic drainage and or ERCP, which is a scope through the bile duct. And typically a stent can also be placed to keep that bile duct open and the enzymes flowing freely. So I hope this helps. This